Hello. Today we have been, unfortunately, 6 months into this COVID pandemic. The whole world is suffering from its consequences. And not only the population as a whole, but even the doctors, the physicians, the healthcare staff, and also the patients. And we had pretty significant disturbances of our way of dealing with patients, dealing with disease, our capacity of attending the patients, even if they needed us during all these months. But from last time, I had the opportunity and the privilege to speak to Drs. Horn and Dr. Warner about COVID in cancer patients. It has been 3 months now, and during these 3 months, we learned a lot of things. We had few studies that clarified a couple of questions, doubts. We have orientations, and these orientations and recommendations changed a little bit for the last 3 months. But at the same time, Dr. Horn and Dr. Warner, they are participating in a very, very important studies and registries in the world, keeping track of patients with cancer and the importance of COVID and the consequences of COVID in these patients. It is the TERAVOLT registry and the CCC19 registry. These two registries now are almost our guidance for numbers, for data, and also they form the basis of the way we think and recommend management of our patients, of cancer patients during this pandemic. So I'm really very honored to be able to discuss again 3 months later. We had our first discussion in early June, and now we are in September. We try to see what's new in these two registries and what changed in the management of our cancer patients. Before we listen to Dr. Warner and Dr. Horn, let me introduce them again. I know that everybody knows them already, but again, Dr. Leora Horn. She is the Ingram Associate Professor of Cancer Research and Director of Thoracic Oncology Program at Vanderbilt Ingram Cancer Center in Nashville, Tennessee. And Dr. Jeremy Warner, Associate Professor of Medicine and Biomedical Informatics, also at Vanderbilt University, and Associate Editor, JCO, Clinical Cancer Informatics. Both they are from Vanderbilt University. And last time, Dr. Warner made it clear that this is not nepotism. They are not working together. They're not taking care of the world because they are in Vanderbilt. But Vanderbilt, and we know that now more than before, it's a very important center for research, registries, and also I learned from the last time we spoke to Dr. Warner, he said that REDCap that we all use here in Brazil and everywhere in the world has been established and produced in Vanderbilt. So Vanderbilt University in Nashville, Tennessee, in the United States is really a hub for science and knowledge. And so I'm really pleased and honored to have you both here. Thank you, Dr. Horn, and thank you, Dr. Warner, to join us. So I will start with Dr. Horn again, as last time. If you could just enlighten us what's new about the study since June up to now. Dr. Horn, please. You have your microphone is off.
Yeah.
Yes.
Trying to keep out my kids. Thank you for having me here today. And so TERAVOLT has continued to accrue data on patients with thoracic malignancies. And right now, we've had 19 countries out of the 28 that have expressed interest that have actually entered data, 130 cancer centers who have entered data into our database. And we have just over 1,100 patients. what we started to look at initially, we were looking at sort of the general patient population as a whole. And we, in the original data that came out, we found that patients with a worse ECOG performance status, those patients who are older age, those patients who were maybe on chemotherapy compared to immunotherapy and TKIs were at higher risk for mortality from COVID-19. What we've now started looking at is the different subsets. And recently at AACR, there was data presented by Alessio Cordellini looking at the patients specifically with small cell lung cancer, mesothelioma, and carcinoids. And we found that particularly the patients with small cell lung cancer were at higher risk for mortality than patients who had either non-small cell lung cancer or these other rare tumor types. We also have been looking at, can we develop a nomogram for a patient that we see as at particular risk for mortality for COVID-19? And we have done that. That data will be presented at ESMO in a couple of weeks. Kind of giving people globally a picture of this particular patient is a patient that's at high risk for mortality from COVID-19. And what we're trying to do with TERAVOLT is not only provide this data on COVID-19, but also provide some practical help for healthcare providers. And so with this data, it gives us information of if your patient has these risk factors, you should be even more deliberate in having those advanced care planning. For oncologists, we've seen improvement in thoracic cancer mortality over the past couple of years. Our patients are doing better, they're living longer. And maybe we've slacked back a little bit on those discussions of what are your goals, what's your of care, what are your advanced directives. And so if you have these patients who you're starting therapy on, or you see these patients have particular risk factors, having those discussions early on that if you get COVID-19, do you want to be hospitalized? Should you be intubated? We also are going to have some data on for the patient who presents with X. In the initial data we had with TERAVOLT, we found that patients with thoracic malignancies were less likely to be advanced to the ICU should they need it. This was because of restrictions within healthcare organizations. This is because there was not enough, some predetermined factors that it was futile for lung cancer patients, maybe some physician bias. But also saying to physicians, in the ICU, if you see a patient with these particular risk factors, maybe you should consider admitting them to the ICU because they have a high risk of recovery compared to patients who present with X, Y, and Z. Their risk of recovery is not high. And that's based on blood-based factors, laboratory lab factors, imaging findings, in addition to the patient demographics. Unfortunately, as you mentioned, the pandemic is ongoing. And so 6 months later, what we're also starting to look at is how did patients do in the first 3 months of the pandemic? How have they done in the next 6 months? And 3 months. And then what are they going to do in the 3 months after that? Because as you know, COVID-19 is not going away. And we've seen a wave from the Northern Hemisphere down to the Southern Hemisphere, as well as countries like India that are being heavily hit with COVID-19. And so how do those differences in outcomes between regions, as well as the timing of the pandemic within a different region? So if it's slower or there are less infected cases, do those patients do better because there is more for the healthcare system to offer them? Or do we not have what we need for the healthcare system to offer them, regardless of the timing, because there are differences in regions of the world and what countries are able to offer their patients? So there's a lot still going on. We're continuing to encourage people to reach out to us to join TERAVOLT. We have several cancer centers in Brazil who are joining TERAVOLT. We don't have the data yet. Of course, Brazil has recently been very hard hit by this pandemic. And so we're hoping that soon we will get some of this data so that we can have an even bigger picture of what's going on around the globe when it comes to COVID-19 and thoracic cancers.
Thank you, Dr. Horn, for this clear and very nice presentation of the data. And the date, I will see that you almost, you have the 3 times more patient than last time we spoke. There's almost 1,100 and over 1,100 patients. That's very interesting. And we will have maybe during the discussion, a couple of questions about these numbers now. And I will welcome again, Dr. Warner. And if you would like to present what's new about CCC19.
Sure, thanks for having me back. It's really hard to believe it's been 3 months, and it's also hard to believe that we're approaching the 6-month birthday of CCC19 and TERAVOLT for that matter. If you want to send us a half cake, we'll be happy to take that. So, I mean, we've been busy. We haven't grown as much in terms of number of centers. We're up to 124 now. I don't remember where we were 3 months ago, but it was probably around 100. So we're slowly adding new centers, but we're certainly seeing a lot more patients coming in. I just checked, and we just are at exactly 4,500 cases reported right now into the database, and we expect to be well on our way to 5,000 pretty soon. Unfortunately, that's really due to what what I'm sure you've seen is it's not really a second wave, since we never really got down from the initial crest, but we saw this big second bulge in the case numbers in the United States, and certain centers actually, for example, our center, which is not just the research coordinating center, but also a participating site, we've seen triple the cases that we saw early on. So because of that, we've seen the case numbers really go up dramatically. Of course, we last met, I think, shortly after our Lancet publication came out, and at that time we had about 1,000 cases. So this is more than 4 times that at this point. And beyond that, we've expanded somewhat internationally. So we're now able to accept sites in Mexico, Argentina, Chile, Colombia, and Panama, and a few others. But one major change that we've made, which is actually making us a bit more like TERAVOLT, is that we're no longer accepting the anonymous reporting, because what we've seen now that we've sort of pivoted from a focus on quantity, or just getting all the cases reported that could possibly be, to really focusing on the quality of the data, trying to address issues around missingness, unknown answers, and lack of follow-up. And with that, we realized that these anonymous reports were not really quite up to the same par as the ones from participating sites. So we've changed our model somewhat. We're still very open to new sites joining, or new individuals, but it has to be through a site, which I believe is how TERAVOLT has been designed from the beginning. What's new since last we spoke is that we published a second manuscript in Cancer Discovery at the end of July, and that manuscript focused on the treatment of COVID-19 in patients with cancer. And this was really prompted by one of our unexplained findings in the initial analysis, which is that patients who received hydroxychloroquine and azithromycin, so that combination of drugs, had a 3-fold increased risk of 30-day mortality as compared to patients who received neither of those drugs. And we had a lot of discussion internally, and I think it maybe generated a lot of external discussion as well about potential confounding, about whether it was a real finding, or if it was something called confounding by indication, or confounding by severity, or both. So we decided to really take a deeper dive into that, as well as looking at the newer treatments, remdesivir, and also high-dose corticosteroids. It was right around the time we began this analysis that the UK recovery trial published their findings about dexamethasone. So we were very eager to see if we could reproduce those findings in our cohort. And so I'm just going to bring up really briefly here. Okay, so just trying to track down the paper so I can have it in front of me. Yeah, here it is. Okay, so we ended up analyzing about just over 2,000 of the cases, and we actually applied some very strict exclusion criteria, which I'm happy to discuss further. But basically, we did everything we could to remove confounders such as, for example, patients who might have been taking these medications at baseline, hydroxychloroquine, azithromycin, these are drugs that people take for other reasons. So we wanted to exclude those patients. We looked at antivirals, so we wanted to exclude patients who were on those anyway. For example, patients with HIV who were on some of the ritonavir and lopinavir, for example. And so, we were pretty rigorous. About a third of our cohort ended up getting excluded before we even started analyzing. And we had several interesting findings. And let me just pull up the the paper again really quick here. I have too many windows in front of me right at the moment. Let's see. Okay, so first of all, what we found is that as you can imagine, not all of the patients in our cohort are actually getting these purported or actual COVID-19 treatments. It's less than half, and the reason for that is that we have a substantial number of patients being reported who are not that sick or just diagnosed as an outpatient, don't really need to take any medications of note, but the patients that did get the treatments, we wanted to understand more about their characteristics, and so we looked at various things like age and race and ethnicity and region and comorbidities, and we found a substantial number of differences in who gets these medications in the first place. So first of all, the biggest driver, and again, I alluded to this before, is the severity of COVID. So if you present with moderate or severe COVID-19, you are much more likely to get a medication for COVID-19. And conversely, if you present with mild, you're very unlikely to get any of these medications. But looking beyond that, age didn't seem like that much of a factor for it, but we did see some really marked differences in receipt of treatments as a function of race and ethnicity. And so notably, one of our main findings was that Black patients were less likely to get the drug remdesivir and more likely to get corticosteroids or tocilizumab. When we drilled into remdesivir a little bit more, this was a statistically significant finding, even after adjustment for many other factors. We believe that the reason is that most of the remdesivir that was available to these patients and continues to be available is not available through every cancer center, and it's also often only available through clinical trials. And so we suspect that those two factors together accounted for that finding. We also found that when you look at comorbidities, they also seem to drive decision-making as to whether or not to use certain drugs. We found that patients with cardiac or cardiovascular comorbidities were less likely to get hydroxychloroquine and azithromycin. And this certainly makes sense because if you read the black box warnings on azithromycin and if you read the FDA guidance on these drugs, even many months ago, there's clear concern about cardiac arrhythmias and other cardiac problems with the drugs. Likewise, we saw that patients with renal impairment were less likely to get remdesivir. But interestingly, we found that patients who were obese or had hypertension were more likely to get any of these COVID-19 treatments. And to us, that suggests that clinicians are reacting to the publications out there about what are the risk factors for bad outcomes of COVID-19. And our guess is that they're preemptively treating patients with those certain comorbidities. So then the next thing we looked at was what happened, were these treatments beneficial for patients with cancer? Or were they potentially harmful? And, as with our first findings, despite additional adjustments, including for the baseline severity, we still found that the receipt of hydroxychloroquine with any other medication was associated with increased risk of mortality. So the absolute risk was not as large as what we found initially with only partial adjustment, but we did have that finding persist. Of course, there's always the possibility we haven't, there's some unmeasured confounder that we haven't adjusted for, but nevertheless, that finding held. On the other side of the coin, we found a suggestion that remdesivir is helpful for mortality. It did not reach statistical significance, but there appeared to be a protective effect with remdesivir. And then finally, we were disappointed, I guess is the word, to say that steroids did not have the same beneficial effects in this population as they seem to have in the UK recovery population. And this was surprising. In fact, there was a signal for increased mortality across the board with steroids, whether they were given alone or in combination with other drugs. So we went back and looked at the UK recovery data to see what happened to the patients with cancer in that cohort. And we found, surprisingly, that the UK recovery folks did not collect cancer as a comorbidity. So they did not report it, and they don't collect it in their case report form. So unfortunately, we can't make a conclusion, I think, about whether patients with cancer benefit from steroids or not. And I think there's a lot of reasons to wonder about steroids in this particular population, not the least because many of them might not have been on chronic steroids, but were getting dexamethasone or similar on a fairly regular basis as part of their anti-nausea treatment for their with their chemotherapy. So I think there's a lot of unanswered questions with steroids in particular. So that's our main update for now. We are presenting two studies at ESMO that I can only talk about a little bit, I believe, because of the embargo. But one of them gets into really looking in much fine-grained detail at cancer treatments and how they might influence mortality. And then the second one being an overall update of our findings with the larger cohort.
Well, thank you so much. It was really a great presentation. And I'm really very, very curious to see all the update that you will be presenting in the next couple of weeks at ESMO. Thank you both for the great presentation. And I have now a curiosity about hydroxychloroquine and the other treatment for patients with COVID. The first question for both of you, if it's possible to answer, what do you feel there is any, because for the last maybe 2 to 3 months, we had several studies that showed that there was no clear benefit in patients with severe COVID infection or patient even where they had mild symptoms. So both of them didn't see any advantage or any benefit. And since those presentations, did you feel that the number of patients, the trend is decreased in the use of hydroxychloroquine, let's say in the first 3 months and then the last 3 months of your cohort, or it's all still random or it's all the same? Do you have any feeling about the trend of the use of the prescription of hydroxychloroquine?
So we have a sense of that. So as a because of the way we collect our data, it's a little bit hard to pin down actual timing of use of the drugs, but because we asked we collect data in interval. So in terms of the COVID diagnosis, we ask how long ago was it? Was it 2 to 4 weeks ago, 4 to 8 weeks ago, and so forth. So we can't pin down exact dates, and that's for PHI reasons, or so that we don't accidentally expose any identifiable patient data. But even with that limitation, I can tell you pretty clearly that the use of hydroxychloroquine has dropped off. It has not gone to zero. And we have to remember that it's almost never the oncologists who are treating, unless it's a mild case that's only seen in the outpatient, it's not the oncologists who are treating these patients. So, we're really relying on our hospitalist and intensivist colleagues to really drive that. They follow guidelines, I think. But there are. I will tell you, I'm having conversations with people in our community that still believe in hydroxychloroquine and just believe that the right studies haven't been done yet, or that the timing in relation to a patient's infection, that the timing wasn't right. That you can't give it too early, you can't give it too late. They think there's sort of like a middle point. But there have been a couple studies that have shown opposite potential benefit, but the vast majority of the studies looking at this drug have not. And I think we see that reflected. Now, when you look at the other drugs, remdesivir, steroids, plasma, we see more use of those drugs in recent days. I think when we did our analysis for Cancer Discovery, we had about 100 remdesivir exposures. The other day I just checked and we're up to about, I'm forgetting the number exactly, but 300 or 400 remdesivir treatments. So and that's just in a month or two. So the use of the drug has gone up remarkably.
Okay.
Got a little bit more. We have a little bit more granular data with TERAVOLT because we designed it from the beginning to collect dates. So it delayed things at some centers, but on the other hand, we know the exact date of the patient's COVID diagnosis, as well as the therapies that were administered. I think that one of the things that has been a bit confusing, so we looked at the steroid question, and we actually found that steroids at the time of diagnosis were associated with higher mortality, but steroids used to treat COVID-19 didn't seem to have an impact. Globally as well, the hydroxychloroquine was only around 20%. I think in the US, a lot of these drugs are being used more than they are around the world. I don't know the data for Brazil, but we will have it. But also remdesivir is not being used routinely in the thoracic patients. Some of it may be that they're not admitted to the ICU, and that's often the place that that drug is administered. Some of it may be that those patients are, it's just a matter of access. In the US, we're a little bit luckier sometimes in the drugs that we're able to access for our patients and what may be available in Brazil and other countries. But a lot of the data and some of the speculation that has happened as well with our steroid question and the hydroxychloroquine is we don't always have the dose of the drug that was given and the duration of therapy. So we know if it was given, but we don't know for each drug. So we don't know if things were given sequentially or if each patient just had the kitchen sink thrown at them. We don't know if it was admitted for a patient. We don't know if it was given always for a patient at the time of hospital admission or prior to hospital admission. We do have the date of the patient's hospital admission, date of death, and things like that. But some of this, I don't think we're ever going to have the true answers without a randomized controlled trial. And while that is going on for agents like remdesivir, it's not going to happen for hydroxychloroquine in the same way.
And I'll add to that there were drugs we wanted to look at and simply couldn't. And the example of that is tocilizumab, which there's rationale to think it might help if cytokine storm is the mechanism of severe COVID. And when we looked, essentially not a single patient got tocilizumab alone. They all got the kitchen sink, as Dr. Horn mentioned. And it was to the point where we just couldn't make an analysis of that drug. But that's the reality of real world data. But unfortunately, the only prospective trial of that agent in patients with cancer is a non-randomized phase 2 trial. And so that's good. That might help understand something, but it's not the same as an RCT. And so, I don't know. I mean, there might be many, of those examples out there. I can't even tell you the number of drugs that are being tested for COVID. I do know there's well over 1,000 trials that are open on clinicaltrials.gov. But I think a lot of those are having a lot of trouble accruing, to be honest. And the hydroxychloroquine ones might have trouble accruing because people have pretty much decided, they don't want to touch that drug anymore, but I don't think those are the only ones that they're having some trouble accruing.
Perfect. For both of you, again, for looking into your data, do you feel that there is a difference in mortality rates of the patients among centers or countries? Do you have any sense of this? Let's say that all over, I know there are the different approaches to the disease, but do you feel there is a big difference between countries or centers within one country on both registries? Dr. Warner?
So we have this in TERAVOLT. We deliberately didn't want to single out centers. Mm-hmm. And so we did look at the countries, but there are differences. We definitely saw the mortality in Italy and Spain was quite high compared to, say, the US. But when you look at the US is essentially 50 countries. Each state, you could say, is a different country. And so if you look at the mortality in Tennessee, we haven't been as high as New York, but New York was so much harder hit by the pandemic. And so I think that some of these differences and the analysis that we're going to be doing is what was the timing of the pandemic? And so that's why it's so important that we're looking at, what happened if you had COVID between March and June in Italy compared to the US, and then what happens if it was June to September but you were in Italy then compared to the US, because I think that we are going to see some differences based on hospitalizations, severity of the COVID-19, and what the patient was offered. You know, our ICU, we're always watching the numbers. You know, if they hit capacity, we've never had to make that decision at Vanderbilt. Do you take a young, healthy patient, or do you take an elderly patient who's 75 with multiple comorbidities? But other parts of the world were making these really hard decisions. And I was actually talking to Dr. Garasino, who's my partner on TERAVOLT, and we've really done everything together. And she said that the numbers in Italy are low, but they're starting to go up again. And she's worried about just the mental health of physicians there having to endure another course of this pandemic and their patients, and what that will do to Italy.
Perfect. We see here in Brazil. We are starting. I live in a big city. It's in São Paulo, and in São Paulo, the number of new cases and then deaths from COVID are going down. For the last 2 weeks, started going down. The curve is going a little bit down. So, but we still see a lot of patients coming into the hospital to be hospitalized and even going to the ICU. I would like to ask you both also about your feeling. Now that the number of patients is going down in the area that is going down, at Vanderbilt, do you feel, did you change your strategy towards the COVID patients? Because we were allocating a huge number of beds in the ICU and the hospital for those patients. But now we don't have those many patients. So what are you doing now in Vanderbilt? Do you feel that you are shutting down areas committed just for COVID patients?
So the short answer is that the strategy changes every week, and that's Vanderbilt's trying to stay on top of the literature. I mean, we get these great emails every week from our Department of Medicine with the latest literature summary, and those often then go into clinical practice guidelines. Again, the steroids, the convalescent plasma, we've seen that go. Now, in terms of physical space, I think one thing that now this is maybe an American phenomenon, because even nonprofit hospitals have to make a profit in America, or they have to bring in revenue, I should say. And so there's a lot of anxiety around dropping revenues and decreased utilization. So I think Vanderbilt and also pretty much every medical center in the US did everything they could to get their volumes back up to normal, their volumes of non-COVID patients. And so, I think that's been achieved. But of course, that begs the question of if there's a surge again, how do you deal with now the normal volumes plus the additional COVID? We hear, at Vanderbilt just recently opened a new wing in the hospital, so we were able to repurpose that as a makeshift, or I shouldn't say makeshift, as a full-blown second ICU with all the intensivists managing it and so forth. So we haven't had any kind of surge issues here, and I think we're sort of maintaining that. But of course, that would be more of a question for the hospital leadership too. But I will say, just briefly getting back to your question about regional variation, it's clearly there, but I think the reasons are complex, obviously, and I'm not sure if we can readily answer them, but we're starting to look into that. I think a major factor is the time course of the pandemic, and we've seen lower mortalities in the West Coast than in the Northeast. And that's been consistent even now that follow-up times are getting longer. But we wonder if that's due to changes in management. The patients in the West Coast are less likely to get any COVID-19 treatments, including hydroxychloroquine, but they might have actually been the beneficiary of a better understanding of what type of non-pharmacological interventions help, such as early proning in the ICU, those kind of things. So really, really hard to know, but something we're actively looking at.
What we've seen some of the, I wouldn't say every service line is back up to normal. So for example, for thoracic cancer patients at our institution, and actually I was talking to someone at another academic institution where patients were traveling 4 or 5 hours to see us. Those patients are more likely to now seek care in their community hospitals. So we're actually seeing that those patients are not coming back to our institution as easily. They're afraid. I think they're appropriately afraid. They're not afraid to come into our institution. So some of the things that went into effect are still there. Everyone gets screened every day. You get your temperature checked. You have to answer questions. Only one visitor is allowed with a patient. You can't have your whole family come for that initial cancer discussion. And that changed because for a while, no one was allowed in with the patient for the inpatient admissions. For the clinic, they were always a little bit more flexible. But the patients, so they're not worried once they get to Vanderbilt, but they are worried about their stop on the way. You know, it's hard for a patient, average age of lung cancer diagnosis is 72. They're going to stop and want to go to the restroom along the way. And so I would not say that we're all, you know, back up and running. The other thing that's being instituted at Vanderbilt, and it's been done at many other centers, is a patient has to have a COVID swab before any procedure. So before you get a bronchoscopy, before you get a biopsy, before you have a surgery. And for some patients, that has been a little bit problematic because say they're coming from 4 hours away, but they want to have their surgery at Vanderbilt, they'll have to come in, get their COVID test, go back home and come back 72 hours later for their procedure. And we are allowing outside tests, but our turnaround is so much faster than other places where patients are having to wait a week for their test results, that they're sort of taking that risk. The other thing that we're doing in our care is for patients getting certain therapies, it was left to the disease teams to decide. For patients with thoracic malignancies, for example, if they're starting chemotherapy, we actually get a COVID swab 48 hours before. Now, I don't know how helpful that is because a patient could be negative or that could be a false negative and have COVID the day they start their chemo. They could also go home, not social distance, and get their COVID that way. I actually heard a nice way of describing it from another physician is that we shouldn't call it social distancing. We should call it physically distancing and socially connecting, which I think is important because so there are changes that we've instituted. But as Jeremy said, we're lucky we've had great leadership. And I think we're also lucky that we were not a hard hit city when it came to COVID-19.
Perfect. Thank you so much. That's a very, I would make the question, what are you doing now? So I see that you basically are still keeping the same pace as you had before. I want to ask you another question. Since we had the studies and the presentations and even recommendations from Italy that for patient, not encouraging patient with lung cancer, metastatic disease to go to the ICU. These are the early recommendations. And so many of the patients didn't even go to the ICU. They were not even recommended to go to the ICU. Do you feel that now at Vanderbilt or through TERAVOLT, you see that the patients are getting more ICU indications and hospitalization than before? Or is everybody still afraid of taking patients with severe COVID infection and metastatic disease in progression to the ICU? What's your feeling?
So I think at our institution, most patients, if they have COVID and they want to be considered for ICU, if it's medically appropriate, they will be offered ICU care. And one of the first patients who died from COVID at Vanderbilt, it was in the newspaper here, had a cancer diagnosis. And so, I think the issues in Italy had to do with the fact that the healthcare system there at the time was very much overwhelmed. And that's where they were making those really, really tough decisions of, do you intubate a 45-year-old young man or do you intubate someone with metastatic cancer? And it's some of the fears that some of us have is that the improvement that we've seen specifically in thoracic malignancies is going to go down as a result of delayed diagnosis now because CT screening programs shut down for a while. delayed therapies because patients won't go get their surgeries or the places are not up and running and able to do biopsies to confirm that diagnosis. I think that we highlighted something with TERAVOLT in our Lancet paper discussing that patients should be offered ICU level care where appropriate, that the risks and benefits should be discussed with the patients. Some of the patients refused themselves, but it was a low number of patients who refused, but some of it was the physician recommendation. I think that physician recommendation should not be autonomous to the ICU doctor. It should be made in conjunction with the medical oncologist on, what is this patient's prognosis? How are they responding to therapy? Or if they're a new diagnosis, what is their likelihood of responding to therapy and what is their predictive survival? I also don't want to, however, encourage futile intubation and admissions to ICUs because there's nothing more traumatic for a family than to intubate someone with hope and have a terminal extubation because you realize that there's no hope. And I think the best way around that is for us as a healthcare community to have that discussion upfront with our patients. I'm giving you chemotherapy. If you get COVID or are infected with SARS-CoV-2, during the time of your chemotherapy, your mortality is probably in the range of 50%. So you need to be cautious as an individual, but you also need to decide that if you are admitted to hospital and you get sick, what do you want? And some of my patients are outright saying, I don't want anything. If I'm that sick, keep me comfortable and let me die. And some of our patients are saying, do everything. So at least we know in what their wishes are, and then I follow up with a conversation that we will do everything, but if I think it's not going to help you and it's actually going to harm you and prolong your death, are you okay with me making those decisions with your family for you? And most of the time, there's that trust there from the patients, and they say yes.
Perfect. Dr. Warner, I'm intrigued about the study, your numbers about hydroxychloroquine and the dexamethasone and remdesivir. And you feel that most of them are, sometimes they hurt more than benefit. But did you find any subgroup of patients that clearly are benefiting from any one of these? A subgroup like these kind of patients, it looks like they are benefiting? Do you find them like a hypothesis generating number?
So we didn't do that. I mean, we sort of went by the rule of thumb that if your main finding is not significant, you shouldn't go look at subgroups. But
you did.
No, we didn't. We didn't look at the but no, I will say that the findings for remdesivir were suggestive. We just didn't have enough power, even with over 2,000 patients. And this is sort of a recurring theme, I think. As you get the larger numbers, you want to look at these bigger or more granular questions, and you keep finding yourself running up against the limits of the statistical power. But that being said, we found similar odds ratios to what were reported in the prospective studies for remdesivir, which were also underpowered to find a mortality benefit, but they were close. I mean, I'm thinking of one study in particular that was published in the New England Journal the one that found the benefit for, I think it was a shorter length of stay, but there was definitely a signal for mortality as well. They just didn't have the power. So that's encouraging, and certainly it suggests that we should redo that analysis once we have slightly larger numbers, and then we could potentially look at subgroups. But this does bring up another thing that I wanted to emphasize is that there is a broad spectrum of outcomes in the population with cancer, and that is based on all the factors we've discussed so far, performance status, the state of the cancer itself, but it's also very much based on what type of cancer the patient is presenting with. And we see, we in our latest update, which was presented at the AACR meeting, we saw a range of a low of 3% for patients with thyroid cancer to a high of 26% in patients with lung cancer. And that number is probably a little underestimated because of our slightly shorter follow-up than TERAVOLT has, for example. But I mean, that's the range. I mean, that's an 8-fold increase of risk, just based on the type of cancer. Now, is it also having to do with the patient factors more than the cancer factors, or with the treatment factors. I mean, certainly these are all intertwined, but it just illustrates what a diverse disease COVID-19 is. And of course, we haven't really even spoken about the asymptomatic patients, but we're certainly starting to see more and more of those kind of come into the registry as people undertake screening, like Dr. Horn was mentioning. We're, I think in the beginning, our rate of asymptomatic patients, which who actually don't have COVID-19. If you look at the definition, they have the SARS-CoV-2 virus, but they don't have the disease. But those only represented less than 5% of our cohort back in May. Now it's more like 15%. So we've definitely seen kind of changes in the makeup of the cohort a little bit over time as well.
I have the last question for you, Dr. Warner, then I go to Dr. Horn. Why not Brazil into your consortium?
So
Argentina, we have nothing against the Argentinians, so why not Brazil?
So first of all, we have a Brazilian in our consortium. That's Dr. Gilberto Lopez.
No, but he's in Miami. He doesn't count for that. He's in Miami.
I do have to say that Dr. Lopez is obviously a huge fan of Brazil, and but I don't know if you know or if your viewers know, but he actually got COVID-19.
Yes. He's a friend of ours. Yes,
he got quite sick, and we were very concerned about him. He was in the hospital, and he's been public about all this, so I'm okay sharing this, but he was in the hospital. He actually got remdesivir and steroids, and he was, I think he was in the hospital for 2 weeks, but fortunately he's out and he's feeling much better, and he's sort of getting back to his normal self. So I think actually that's obviously we all have to remember, you know, I think we have the tendency to focus on the mortality and the bad outcomes, but we do have to remember that there are many survivors, even in the patients with cancer population. You know, the majority, I think, should survive. So, but we do have to think, you know, going forward, we think about late-term effects. We're actually working with ASCO right now to try to create a unified survivorship collection instrument. But back to your question about Brazil, my understanding the last time we spoke with our legal folks is that your very strict privacy law that went into effect, I think around July 1, actually prohibits us from collecting data from Brazil. My understanding is that it's stricter than GDPR. But what I heard from Dr. Horn earlier is that she's actually got some Brazilian colleagues that will donate data. So I'd love to revisit that, because unfortunately, as you well know, I think you're the second worst hit country in the world, just beyond us. So certainly it would be beneficial. But I do know that Gilberto has spoken with. I'm going to get the acronym wrong, but he's spoken with the leadership of your cancer. Basically your version of the NCI, and my understanding is that there will be, you know, some way, hopefully, of getting data. But at the very least, we have provided our survey in Portuguese. We had that translated some time ago, and so I'm not sure if people are actively using it, but it's out there for people to use if they wish.
Thank you, Dr. Horn. My last question for you: what about small cell lung cancer? Small cell lung cancer. Do you feel that the outcome is different? We know that the mortality is a little bit higher, but stage by stage or performance status by performance status. Do you feel that will you have to single out the small cell lung cancer patients, different management for COVID infected patients?
I don't know if we should manage them differently, but we should definitely have those discussions with them. You know, many patients with small cell are diagnosed in the hospital. And we know that sometimes hospital can be a place where patients actually contract COVID-19, despite hand washing and PPE and healthcare providers being very careful. They're also a slightly older patient population than the non-small cell patients. They are the patients with a smoking history, have the worst performance status, and have multiple comorbidities. So I don't know that we need to treat them differently, but what we do need to do is just be aware that if they do develop COVID-19 and they are infected with SARS-CoV-2, that they are a patient demographic that'll be at high risk for mortality as a result. You know, it's interesting. You were asking Jeremy, you know, what's missing. or, which therapies help. I think one of the other things that we need to bother companies about is what's missing in a lot of the vaccine trials is cancer patients. So if there is a vaccine available, or let's say when, because we're hopeful, we won't know sort of should cancer patients be diagnosed, should they be dosed the same? Do they need something extra? And I'm really hoping to see a global vaccine trial that's available for patients with cancer, because they are a very high-risk population, no matter what their tumor type.
Would you recommend to your patients with lung cancer to get the vaccine as soon as it's available? What we're going to do?
I probably will. I recommend to all my patients that they have to get a flu shot this year, even those who generally refuse one. If they're not coming in because they're on a tyrosine kinase inhibitor, I'm letting them get away with it. But if there is a vaccine that's been shown to be available, that's been shown to be beneficial, I will definitely encourage my cancer patients to get it, because, it's if it can save their life, if they're going through all this treatment to save their life and then die of an unfortunate virus, then what have we put them through?
Okay. Well, thank you so much, Dr. Horn. Thank you so much, Dr. Warner. It was really an enlightening discussion. Thank you again. I hope to see you maybe 3 months from now and see what's new about your registries. I'm really honored to having you with this discussion. Thank you so much for both of you.
Thank you.